Hello and welcome to a recorded version of the Community Connector training that has been provided as part of the Core 20+5 programme into children's oral health, and the training is being provided by Scottish Community Development Centre. My name's Andrew Patterson, I'm from Scottish Community Development Centre, and it is being commissioned by the three Healthwatches, that's Healthwatch Bucks, Healthwatch Oxfordshire and Healthwatch Reading. The first training session is on health and your community. Now, as I said, my name is Andrew Patterson. I'm from Scottish Community Development Centre, and we're able to provide this training because it's online, even though we're far away. I'm based up in Glasgow, but it's something that we do a lot of work in, helping communities engage with other people in the community, speak to them, people connecting up with public services, trying to shape them, influence them. The other way around, we work with public services who are trying to work with people in the communities or service users. So we do a lot of stuff with communities. So to start off on health and your community, we're going to look at causes and cures. So imagine a friend of yours has a streaming cold. They're sneezing, coughing, and feeling hot and shivery. They have had a lot to deal with. They've got many problems lately, and their home suffers with dampness. Now, in the training session that was provided live, we asked you to discuss the causes and cures of this person's cold. We weren't going to be too prescriptive. We weren't going to make you have to think about this one example. We just wanted you to think about the reasons that you think people might catch the cold, the things that you talk about and think about in everyday life, and also what people in your family and what people in the community might think as well, maybe even what health professionals might say. But not just what caused the cold, but what treatment or remedies or even things that might prevent the cold might you suggest or might others suggest. And from the discussions, we concluded that health is more than about the treatment of illness. It's not just about catching something, developing some illness, and then being treated. There are other causes that are there as well. And we were discussing things like housing, the food that we can buy, transport services, public services, education, and social contact. So all these things were seen to have an influence on our health. And we showed this diagram which had, in the bubbles, you can see all the different things that contribute to health. We've got things that were in those pictures, such as housing and places, transport and travel, education and work, social connections. We've got another couple of things added there, mental health and well-being, the environment. And then we've got this one towards the middle here, poverty and inequalities. Now this bubble relates to just about everything else, because if you are experiencing poverty and inequality, then a lot of these other things will be reduced for you. You won't have as much in the way of good quality housing, educational opportunities. You might have a poorer environment. Your mental health and well-being will suffer. So it all contributes to a downward spiral of health in a lot of cases. And to illustrate this further, I used an example from Aberdeen in Scotland, city of about 250,000 to 300,000 people. And we indicated that we showed how if you use this online resource called the Social Index for Multiple Deprivation, don't worry too much about the jargony terms there, but basically you can go online and look at the different areas in a city or a town or village, such as Aberdeen and see the different levels of poverty or the levels of affluence, how wealthy people are. I mean, that's putting it in a quite simple way, but it is quite a useful way of mapping wealth and deprivation, poverty in other words. In the red areas, that is where poverty is higher. People don't have as much money. Other things are happening there too, probably more crime, probably more of a transient population. That means people coming and going more, less services. Whereas in the blue areas, that's where people tend to be more wealthy. And we compared two areas in Aberdeen, one called Midstocket, which I've ringed there, and then Maastricht, which is close by to Midstocket, relatively speaking, but has a lot more red. And when you look more closely at these areas and compare some of the different profiles of the areas, you can see that compared to Midstocket, Maastricht has a lot more areas that are coloured orange in this table, and basically that's showing that compared to average, they have worse statistics for things like crime, for employment, for screening and immunisation. Not everything is going to be orange, some things are blue. The grey, the things that are lit up grey are showing where things are around average. But if you looked at a lot of different areas that experienced more deprivation or poverty, you would see that there tends to be more orange in those areas. And the same goes for health and well-being. You can see that in Maastricht, there are a lot more indicators for health which are coloured orange, and that includes emergency hospitalisations and coronary heart disease. So again, looking across different types of illness and life expectancy, you tend to find that areas that don't have as much in terms of resources, income, employment, will also be worse in terms of health. And so then we looked at an example from a theorist called Zola, who used this anecdote or illustration which told a story to try and illustrate a certain point about how we think about health and how we deal with health in our society. So the story goes, there was once a man standing by a riverbank, happily watching the world go by, and to his horror, he suddenly saw a person floating downstream and in distress. Without hesitating, he flung off his jacket and jumped in the water. So this guy is quite heroic here. He's going in to rescue this person. He pulled them out, got them onto the bank, and got them breathing again. So a great story there. But when he saved this person, he saw somebody else floating by and struggling in the water. So he felt he had to go and save them too. But so the story goes, and it is a made-up story, more and more people started floating downstream, and he couldn't rescue them all. And what the point of the story is really that Zola was saying that our medical system, our hospitals, our doctors and nurses, they are rescuing people on the whole. When people present an illness or poor health, mental illness, doctors and nurses are there, hospitals are there, experts are there to help to get people better again. But what we don't do enough in our society is look upstream to see why people are getting ill in the first place, or according to the story, why people are in the river in the first place, floating downstream. So what's pushing them in? And the point is that unless someone takes a look upstream and begins to work on what is causing all these people to drown, more and more people are going to get into difficulties or die. Another approach is to try to do both things at the same time. We need to support and help people, so doctors, nurses, hospitals are necessary. People will get ill and people will die sometimes and die younger, and hospitals and doctors and nurses are there to do a really important job. But at the same time, we can also work together to try to prevent some of these things from happening. And so what we looked at was that there are different ways to think about health. The medical model, which is more like what we currently do, focuses on treatment, whereas this other way of thinking, which you can call the social model of health, focuses more on the causes of illness and health and poor health. The medical model tends to be done by health professionals. The social model can be done by a lot of different people, including people in government making decisions and planning better ways of doing things, but also right down to people working or people in communities. We can be supporting each other in various ways. We're not wanting to pass on the responsibility to people in communities to only be there to look after each other. That's not what we're saying. But there is, people in communities do have influence over each other and each other's health. The medical model focuses more on diagnosing and treatment. It's more downstream. Whereas the social model thinks about prevention, and that's going back to the story about people floating downstream and trying to prevent that. And so the medical model's main aim is to free us from pain, disease, and defect. And the social model is thinking more about wider well-being. So the other things that are causing us to get ill, or to other things that can make us feel well, or contribute to our happiness and confidence and social connections and all the different things that are important to our lives and well-being. So we're starting to get a little bit towards the idea of the role communities have. We looked at, in the table before, at this idea that communities even have a contribution to make to our health and well-being. And it's just maybe quite good to quickly go over what we mean by community. And the definition that we use is that a community is a group of people that are united by at least one common characteristic. That could be where they live or place. It could be characteristics of that community, and that's more like identity. And that could be things like our ethnic background or our being from a disability, having a disability. It could be around shared interests, some of the things that we are involved in, maybe people that are trying to campaign about a particular issue, or people who are carers. They could be a group who are have a shared interest. And so where does community fit in terms of health and well-being? Well, communities are impacted on differently and unfairly by inequality. So all the things we were looking at so far, and we were looking at poverty and different areas that are affected by poverty more, well, the communities in those areas are impacted on differently, and it is unfair. If you're born into one of these areas, your opportunities for having a healthier, longer life are much smaller. You don't have as much of an opportunity to be healthy and live a longer life. And communities have an important role in improving health, in ensuring that we prevent illness and health and poor health from happening in the first place. And I'll say a bit more about that. And what we explored in the workshop was what type of things might happen in communities that can improve health. So I asked people to think about that, and we had a conversation. And we used a few prompts, some pictures to try and get us thinking. So we've got, activities that people are doing. People that are involved in some kind of cooking class. People that are involved in training and learning. And then also the back picture there, importantly, people that are involved in conversations and possibly just having a voice. And that's one of the really important things we wanted to say. Why do people's voices matter then? Well, not everyone has the same experiences. A lot of people will be having different experiences, and people will know important things about their lives and communities that others don't. Without having people involved, decisions can be made that make things worse. So in particular, we want to have the voices of people who are worst affected by inequality and poverty to be involved in trying to think of ways and work towards improving the situation. If you don't have them involved, then the decisions are going to miss out on important things and possibly end up making things worse. And what we call this type of thinking, or this idea, we have an idea called lived experience. And you might have heard that term before. And it's simply referring to the fact that through the experiences we have a level of expertise that other people won't have. So we're not thinking of ourselves as professional experts, but there's an equally important type of expertise, which is your lived experience and what you can bring to the discussion about how to make things better based on things that you know through your regular lived experience. So what is a community connector? Because we're getting to the point of thinking about what it is that you would be doing as a community connector and why it's important. And that is reaching people, having conversations, gathering stories, getting voices heard. So in other words, being a community connector is a way of tapping into lived experience. Your own lived experience is important, but you're helping to reach others and bring a range of different voices from your community into the mix and helping to understand problems, situations, and coming up with solutions. And taken together, that is a really important part of prevention. So working upstream, we can think of the people in communities as being upstream, knowing what the reasons and problems and situations are that lead to some of the problems that people experience further downstream. So that's it for this session, and in the next session we'll be talking about ways to reach people as a community connector, how to gather stories, but also thinking about protecting your own and others' well-being. So thank you very much. We'll be putting these slides and links to further information and materials on the following website. And you should feel free to get in touch. My email is there, and good luck with it. Join us for the second session if you can.